There is no alarm. At 7:42 she answered every question. By 8:15 she was a little slower. And just now, at 8:40, she could not find the word for the pen in her own hand. Her right hand has drifted off the blanket, and no monitor in this room is making a sound. Which side of her brain, and how long has this been happening? Because one of those answers is a clock that started running before anyone noticed. By the end of this, you will read a level of consciousness, a pupil, an EEG, and a stroke scale, and know what to do first. This is neurology, all of it. Let's build it from the ground up. Chapter 1. The wire and the map. Everything the nervous system does runs on one cell doing one trick. A neuron sits at a resting charge, slightly negative inside. A strong enough signal flips it. Sodium rushes in, the charge reverses, and that flip races down the axon as an action potential. Here is the part that matters clinically. The axon is wrapped in myelin, and myelin lets the signal jump from gap to gap, fast. Strip the myelin away, and the signal slows, scatters, or stops. Hold on to that. Multiple sclerosis and Guillain-Barré are both what happens when the wire loses its insulation. One color key for this whole course, and it is the most important decision we will make. In a stroke, the dead center is the core, and we will draw it gray-blue. Around it is tissue that is starving but still alive, the penumbra, and we will draw it amber. Gray-blue is already gone. Amber is what you are racing to save. Cerebrospinal fluid is cyan. Myelin is teal. Watch for those colors the rest of the way. Now the map. The cerebrum has 4 lobes. Frontal, up front, runs movement, judgment, and personality. Parietal senses and interprets. Temporal handles hearing, memory, and language. Occipital, in the back, is vision. Underneath, the cerebellum coordinates balance and smooth movement. And the brainstem runs the things you never think about. Breathing, heart rate, wakefulness. Damage a lobe and you lose its job. Damage the brainstem and you lose the patient. 2 wiring facts that answer a huge share of neuro questions. First, the brain is crossed. The left hemisphere controls the right side of the body and the right hemisphere controls the left. So right-sided weakness points to a left brain problem. Second, in most people, language lives in the left hemisphere, which means a left brain stroke often takes speech and the right side of the body together. Remember our patient. Right hand, and the missing word. Same side of the brain. So here is the frame for the entire course. Every neurologic disease is the wire failing to carry a signal, the map losing a specific function, or pressure rising inside a closed box. That is it. A conduction problem, a location problem, or a pressure problem. When a chapter stops making sense, come back to these 3. Our patient is Eleanor, 63. The right-sided weakness and the word-finding trouble tell you the problem is in her left hemisphere, in the territory of a specific artery. But before we chase the artery, you have to be able to measure a brain, quickly and repeatedly, in numbers. Because the single most important thing about brain injury is not where it is whether it is getting worse. Chapter 2. Pressure in a closed box. The skull is a sealed, rigid box, and it is completely full. 3 things fill it: brain tissue, blood, and cerebrospinal fluid, and together they equal 100%. This is the Monro-Kellie doctrine, and it is the key to this entire chapter. If any one of the 3 grows, a bleed, a tumor, swelling, something else has to shrink, because the box cannot expand. So at first, the body compensates. It pushes CSF and blood out to make room, and the pressure stays flat. The patient looks fine. Watch the gauge, it is not moving. And then compensation runs out. There is nothing left to push out. Now every tiny increase in volume sends the pressure straight up. And the curve that was flat turns almost vertical. This is the most important shape in neuronursing. The patient who looked stable for hours crashes in minutes, not because the injury suddenly changed, but because the compensation just ran out. Intracranial pressure above 20 is treated. And the deadly part is how quietly the patient sits right before that corner. Here is why the pressure matters. The brain needs blood, and the pressure pushing blood into the brain is your mean arterial pressure minus the intracranial pressure. So, when ICC climbs, it directly subtracts from brain perfusion. High pressure in the box literally squeezes the blood supply out. That is why we care about a number you cannot see in a patient who is not yet complaining. So what does rising pressure look like? Early, the most sensitive sign is a change in level of consciousness. Restlessness, confusion, drowsiness, then headache, then vomiting, often without nausea. A pupil that becomes sluggish, then fixed and dilated on one side, is the pressure pushing on a nerve. And the late, ominous one is Cushing's triad. Rising systolic with a widening gap between systolic and diastolic, a slowing heart rate, and irregular breathing. Cushing's triad is not an early warning. It is the brainstem being crushed. If the pressure is not relieved, the brain does the only thing it can. It shifts. Tissue is forced across the midline, and then downward through the only opening in the box, the base of the skull. That is herniation, and it compresses the brainstem, the part that runs breathing and heart rate. A blown pupil and a sudden drop in consciousness are herniation until proven otherwise. So how do we lower the pressure? Position matters. Head of the bed up about 30 degrees and the head midline, so the veins can drain. Keep them calm, treat pain and fever, because both raise pressure. Hypertonic saline or mannitol pull water out of the brain, and avoid anything that spikes pressure, suctioning too long, straining, a flat position. One trap to lock in. You do not give a hypotonic fluid, and you do not overhydrate a brain that is already swelling. Pause. Your head-injured patient has been stable for hours. Now the level of consciousness has dropped 1 point, and the right pupil is slower to react than the left. The blood pressure and heart rate are still normal. What does this mean, and what do you do? This is rising intracranial pressure, early, and you act now. The changing level of consciousness and the sluggish pupil are the sensitive signs. Do not wait for Cushing's triad or a fixed pupil. Those come after compensation has failed. Raise the head of the bed, ensure the neck is midline, and notify the provider immediately. The strongest wrong answer is to reassess in an hour. In an hour, this patient may be herniating. Eleanor's pressure is not the problem yet. Her brain is not swelling. Something is blocking blood from getting in. But you cannot know that from across the room. You know it by assessing her, in numbers you can repeat every 15 minutes and compare. That assessment is Chapter 3. Chapter 3. Reading the brain. Glasgow Coma Scale turns consciousness into a number you can trend. 3 responses: eyes, verbal, and motor. Eyes score 1 to 4, verbal 1 to 5, motor 1 to 6. Add them. The best possible is 15, the lowest is 3, and 3 means no response at all. The number everyone should know is 8. A GCS of 8 or less means the patient can no longer protect their airway, and that is the threshold where we intubate. Below 8, intubate. But the single value matters less than the direction. A GCS that drops from 15 to 13 to 11 over an hour is an emergency, even though 11 by itself is not a disaster. 2 points down is a red flag. Always score the best response, and always compare to the last one. And when you report it, give the breakdown, not just the total, because eyes 2, verbal 2, motor 4 tells the provider far more than the number 9. Now the pupils, because they are a direct window onto the brainstem. Normally both are equal, round, and briskly reactive to light. One pupil that blows, becoming large and fixed, is pressure compressing the nerve on that side, and it usually matches the side of the problem. Pinpoint pupils suggest opioids or a Pons lesion, and bilateral fixed and dilated pupils are an ominous, late brainstem sign. A new unequal pupil is never something you note and move on from, it is something you escalate. 2 more tools. A non-contrast CT is the first scan in almost any acute brain event because it is fast, and it answers the one question that changes everything. Is there blood? MRI sees detail and early ischemia better, but it is slower, and a lumbar puncture samples the spinal fluid. But there is a rule you cannot break. If intracranial pressure might be high, you do not do a lumbar puncture, because releasing fluid from below can pull the brain downward and cause herniation. Pause. For findings in a head-injured patient, which one do you report first? A slight headache, a single episode of vomiting, a GCS that went from 15 to 12 in 30 minutes. or a blood pressure of 138/82. The falling GCS 15 to 12 in 30 minutes is a rapid decline in consciousness, the most sensitive sign that something in the brain is getting worse right now. The headache and the single vomit are concerning but non-specific, and that blood pressure is normal. The trend is the emergency. Eleanor scores a GCS of 14. Eyes open, she is confused. She follows commands with her left side but not her right. Her pupils are equal. So this is not primarily a pressure problem. It is a function problem on the left side of her brain, and it started somewhere around 8:15 this morning, which means the clock has been running for less than an hour. And in the next chapter, that clock is everything. Chapter 4. Time is brain. Stroke is the brain losing its blood supply, and there are two completely opposite ways it happens. In an ischemic stroke, a clot blocks an artery and starves the tissue downstream. That is about 85% of strokes. In a hemorrhagic stroke, an artery ruptures and bleeds into the brain. Same word, opposite problem. And this is why the very first step in any stroke is a CT scan, because the treatment for one is the exact thing that would kill the other. You cannot give a clot buster to a brain that is bleeding. Here is why every minute counts. When the artery blocks, the center of the territory dies quickly. That is the core, gray-blue, and it is gone. But around it is the penumbra, amber, tissue that is starving on the edge of the blocked supply but still alive, kept barely going by neighboring vessels. That amber rim is salvageable brain. Every minute without flow, the gray-blue core spreads outward and the amber shrinks. Time is brain means, quite literally, amber turning gray-blue. That is what you are racing. Recognition has to be fast, so the sign is built into the word. F. Facial droop, one side. A. Arm drift, one arm falls when both are raised. S. Speech, slurred or wrong words. T. Time, note when the symptoms started and call immediately. And that T is not a slogan. The time the patient was last known well is the single piece of information that decides which treatments are still on the table. For an ischemic stroke, the clot buster is a drug called TPA, and it is all about the window. It is given within about 4.5 hours of the last known well time and never before a CT has ruled out bleeding. Then the contraindications, because this drug dissolves clots everywhere, not just the one you want. Recent surgery, recent bleeding, a bleeding disorder, very high blood pressure, or a recent stroke all take it off the table. After TPA, the watch is for bleeding, and a sudden headache or a falling level of consciousness means stop and scan. If the clot is in a large vessel, there is a second option with a longer window. Thrombectomy, where a catheter is threaded up into the brain and the clot is physically pulled out, sometimes up to 24 hours out in selected patients. And notice the blood pressure rule flips depending on the plan. Before we open the artery, we tolerate a higher pressure to keep the penumbra perfused. It is one more reason you never manage a stroke by reflex. Pause. A patient arrives with left-sided weakness and slurred speech that started 90 minutes ago. The CT shows no bleeding. Which order do you question? Give TPA, obtain the last known well time. Give aspirin immediately, or keep the patient NPO until swallowing is assessed. You question the immediate aspirin. In a patient who may be about to receive TPA, giving aspirin first adds bleeding risk before the clot buster is even started. The last known well time, the NPO status, and TPA itself are all appropriate. Aspirin has a role in stroke, but not in the minutes before thrombolytics. Sequence is the whole answer. Eleanor's CT shows no blood and a blocked branch of her left middle cerebral artery. She is inside the window, she gets TPA, and because the clot is large, she goes for thrombectomy, and the artery is reopened. The amber penumbra that was minutes from turning gray-blue is saved. But the course she lost in the first hour is permanent, and now the real work begins. Because a brain that survives a stroke is not the same brain. Chapter 5. After the stroke. Which side of the brain the stroke hit tells you which patient you are about to care for. A left brain stroke, like Eleanor's, gives right-sided weakness and, in most people, aphasia, a problem with language. These patients are often anxious and cautious because they know something is wrong but cannot say it. A right brain stroke gives left-sided weakness and something stranger, neglect, where the patient ignores the left side of the world entirely, and often a dangerous lack of awareness of their own deficits. Left brain, careful and frustrated. Right brain, impulsive and unaware. Aphasia splits two ways, and the difference is testable. Expressive aphasia, the patient knows exactly what they want to say and cannot get the words out. It is frustrating, and they are aware of it. Receptive aphasia, the words come out fluently but do not make sense, and the patient does not understand you. Expressive, the message is stopped going out. Receptive, the message is scrambled coming in. Give the expressive patient time and yes or no questions. Do not rush them. And here is the complication that actually kills stroke patients after they survive the stroke. Dysphagia, trouble swallowing. A brain that cannot coordinate a swallow lets food and liquid slip into the lungs, and that is aspiration pneumonia. So, before a stroke patient gets anything by mouth, not even water, not even their pills, they get a swallow screen. Keep them NPO until it is past, sit them fully upright to eat, and watch for coughing or a wet, gurgly voice. This is the most tested piece of stroke aftercare there is. Pause, and select all that apply. Your stroke patient has not yet passed a swallow screen. Which actions are appropriate? Keep the patient nothing by mouth. Sit them fully upright. Give their oral medications with a small sip of water. Have suction available. Or, thicken all liquids before the screen is done. Nothing by mouth, sit fully upright, and have suction available. Those protect the airway. You do not give oral medications, not even with a sip of water, until the swallow screen is passed. And you do not start thickened liquids on your own before a formal evaluation decides the right consistency. When in doubt, the airway wins. Keep them NPO. Eleanor keeps her right-sided weakness and her expressive aphasia at first. She knows the word and cannot say it, and that is agonizing for her, so the team gives her time and never finishes her sentences. Over weeks, with therapy, the amber tissue you saved comes back online, and the words return. She will recover. But while she was recovering, on the third night, the monitor you were told this room did not have, alarmed. Because her brain had one more way to fail. Chapter 6. The Electrical Storm. A seizure is a sudden burst of disorganized electrical activity in the brain, and on the EEG it is unmistakable. The calm, low-voltage background erupts into high-amplitude, chaotic discharge. A generalized tonic-clonic seizure has two phases. Tonic, the body stiffens. Clonic, it jerks rhythmically. But some seizures are almost invisible. An absent seizure is just a blank stare, and on the EEG it is a clean 3 per second spike and wave. Not all seizures shake. Some just stop. What you do during a seizure is mostly about protecting, not stopping. Do not restrain them, and do not force anything into the mouth. Turn them onto their side so secretions drain and the airway stays clear. Protect the head, move dangerous objects, and time it. The timing is not a detail. It is the decision point for the next slide. And when it is over, they will be confused and exhausted. That is the postictal state, and it is expected. Here is the emergency. A seizure that lasts more than 5 minutes. Or seizures that come one after another without the patient waking up in between. Is status epilepticus. On the EEG, the storm never stops. This is a true emergency, because the brain is burning through oxygen faster than it can be supplied, and neurons start to die. Airway and oxygen first. The drugs are benzodiazepines to break the seizure now. Then a longer-acting anti-seizure medication to keep it from coming back. 5 minutes is the line. Medications you support these patients on have their own rules. They are taken exactly on schedule, at the same time every day, and never stopped abruptly, because abrupt withdrawal can itself trigger status epilepticus. Some require blood level monitoring. And the teaching is safety. No driving until cleared, no swimming alone, and know the triggers. Missing a dose is not a small thing here. It is a seizure risk. Pause and put these in order. You witness the start of a generalized tonic-clonic seizure in your patient. What is the sequence of your actions? Stay and call for help without leaving the patient. Ease them to the floor or lower the bed and turn them onto their side. Protect the head and clear nearby objects. Time the seizure. And when it ends, keep them on their side, suction if needed, and reorient them through the postictal confusion. Note what you never do. You never put anything in the mouth, and you never restrain. Eleanor's third night event was a focal seizure, scar tissue from the stroke becoming an irritable focus, which is a known complication. It was brief, it self-resolved, she was started on a scheduled anti-seizure medication, and she was fine. Not every brain injury comes from the inside, though. Sometimes the box takes a hit from the outside, and everything you just learned about pressure comes back at once. Chapter 7. Impact. Trauma bleeds into the head in 3 classic patterns, and telling them apart is high yield. An epidural bleed is arterial, between the skull and the covering, and it has a signature story. A blow, a brief knockout, then a lucid interval where the patient seems fine and talks to you, and then a rapid collapse as the arterial bleed fills the space. A subdural bleed is venous, slower, and can show up hours to weeks later, especially in older adults and people on blood thinners. And a subarachnoid hemorrhage, often from a ruptured aneurysm, announces itself as a sudden thunderclap headache, the worst headache of their life. That epidural lucid interval is a classic trap, so lock it in. A head injury patient who was knocked out, woke up, and seems perfectly fine is not necessarily safe. The arterial bleed is filling silently behind a normal-looking exam, and when it runs out of room, remember Monro-Kellie, they fall off the cliff fast. Talk and die is the grim phrase for it. Anyone with that story gets watched closely and scanned, not sent home. Now the spinal cord, where the rule is, stabilize first, and assess without moving. Any suspected spinal injury gets the spine immobilized before anything else, because a cord that is bruised can still be saved, and a cord that is severed by movement cannot. The level of the injury tells you what is lost below it. And injuries high in the cord threaten the muscles of breathing, which is why a high cervical injury is an airway emergency. 2 cord emergencies you must separate. Neurogenic shock, soon after a high injury, is the loss of sympathetic tone. Low blood pressure, a slow heart rate, and warm, dry skin, the opposite of the fast heart rate you expect in other shock. And autonomic dysreflexia, later, in injuries at T6 or above, is the reverse. A dangerous spike in blood pressure with a pounding headache, triggered by something below the injury, most often a full bladder. The action is immediate, sit the patient up, and find and remove the trigger. Check the bladder first. Pause for a bow tie. A patient with a spinal cord injury at T4 suddenly develops a severe pounding headache and a blood pressure of 210/110. Choose the condition, the 2 priority actions, and the 2 things to monitor. The condition is autonomic dysreflexia. The actions: sit the patient upright immediately to drop the pressure, and find and remove the trigger, starting with a distended bladder. The parameters to monitor: blood pressure, which can climb high enough to cause a stroke, and the symptoms, the headache and flushing that tell you whether the trigger is resolving. Lying the patient flat here would be the dangerous wrong move. Eleanor's story is not a trauma story, but the patient in the next bed is. And when both were stable, the difference between them was not the injury. It was whether the wire itself, the peripheral nerves, could still carry a signal to the muscles. That is a different kind of failure. And it is Chapter 8. Chapter 8, when the signal fails. Remember the myelin, the insulation on the wire. 2 diseases attack it. Multiple sclerosis is the body attacking the myelin of the central nervous system, in scattered patches, over years. The signals slow and misfire, and the hallmark is symptoms that come and go and are made worse by heat. Guillain-Barré is the opposite in tempo, an acute attack on peripheral myelin, often after an infection, and it is ascending. Weakness that starts in the feet and climbs. The danger is obvious once you see it climbing. When it reaches the muscles of breathing, the patient stops breathing. Watch the vital capacity, not just the oxygen saturation. Myasthenia gravis is a problem at the connection between nerve and muscle. The receptors that receive the signal are blocked, so the muscle fatigues with use. The classic picture is drooping eyelids and double vision that get worse as the day goes on, and worse the more the muscle is used. It improves with rest. The dangerous version is a myasthenic crisis, when the weakness hits the breathing muscles. And here is the distinction that is pure NCLEX. In myasthenia gravis, two opposite crises look almost identical, both severe weakness, but they have opposite causes. A myasthenic crisis is too little medication, the disease breaking through. A cholinergic crisis is too much medication, you tell them apart by the extra signs of overdose. Excessive salivation, tearing, and GI cramping point to cholinergic, too much drug. Both threaten the airway, and the airway always comes first, but the fix is opposite. One more, briefly, because it anchors the others by contrast. ALS destroys the motor neurons themselves, progressively, while sensation and the mind stay intact. The patient feels and thinks everything, in a body that stops answering. There is no myelin to blame and no junction to fix. It is the wire itself dying. Care is supportive, and the priorities are swallowing, breathing, and communication. Pause. A patient with Guillain-Barré reports that the weakness that started in their feet this morning has now reached their hips and they feel short of breath. Which assessment is the priority? The priority is respiratory, specifically bedside pulmonary function, the vital capacity, and the work of breathing, because ascending paralysis that has reached the trunk is climbing toward the diaphragm. Oxygen saturation is the trap here. It can look normal until the moment the patient tires out and fails, because saturation drops late. You are watching for the climb, not waiting for the number. These are the diseases where the emergency is almost always the same organ, the lungs. When the wire to the diaphragm fails, breathing fails. And that is what you watch for in every one of them. Eleanor never went there. Her recovery held. But some neurologic losses do not come as a crisis at all. They come slowly, over years, and they are their own kind of hard. That is Chapter 9. Chapter 9. The slow losses. Parkinson's disease is a shortage of dopamine in a small motor control center deep in the brain, and it produces a specific quartet. A resting tremor, often a pill-rolling motion of the fingers. Rigidity, a stiffness that ratchets. Bradykinesia, a slowness that makes movement hard to start. And postural instability, a stooped, shuffling, unsteady gait. The face becomes mask-like. The safety issue that matters most is falls, and the second is swallowing. Medications replace dopamine, and they are timed carefully around meals and movement. Alzheimer's disease is the slow loss of the brain itself. Neurons die, the cortex thins, and memory goes first, recent memory before old memory. Then language, judgment, and the ability to do everyday tasks. The distinction to hold is delirium versus dementia. Delirium is sudden, fluctuating, and often reversible. An acute confusion from infection, drugs, or metabolic upset. Dementia is gradual and progressive. A patient with dementia who becomes suddenly, acutely worse is not just their dementia. They have a new delirium on top of it. And you go looking for the cause. Caring for these patients is mostly environment and safety. Consistent routines, simple choices, and a calm, well-lit space reduce agitation. Reduce fall risk relentlessly. And support the caregiver, because the caregiver is the patient you do not see. For delirium, the nursing win is prevention, orient them, get their glasses and hearing aids on, protect sleep, manage pain, and find the reversible cause before it does harm. One acute item belongs here because it is a can't miss. Meningitis, inflammation of the lining of the brain, presents with fever, a severe headache, a stiff neck, and photophobia. Suspected bacterial meningitis is a race. Blood cultures, then antibiotics. Do not wait for the lumbar puncture results. And because it can be contagious, the patient goes on droplet precautions until it is ruled out. A stiff neck with fever and a new headache is meningitis until proven otherwise. Pause and read the trend. A patient with known mild dementia has been at their baseline for months. Over the past 12 hours, the nurse notes they have become acutely confused, are seeing things that are not there, are drowsy then agitated, and have a low-grade fever. What is happening? This is delirium, most likely from an infection, superimposed on their dementia. The tells are the time course and the fluctuation. Hours, not years, and a level of consciousness that swings from drowsy to agitated. Dementia does not do that. The wrong move is to write it off as the dementia progressing. Acute on chronic confusion is a new medical problem until you have found and treated the cause. And here, the fever is pointing at 1. Eleanor goes home. Her words are back, her right hand is nearly back, and she knows the warning signs now better than most nurses. Which leaves one last thing. Taking everything, the wire, the map, the pressure, the clock, and using it on a patient you have never seen. That is Chapter 10. Chapter 10, Put it together. Every neuro decision collapses into the same 6 questions the next generation NCLEX is built on. What is happening? Recognize the cues. Why? Is it the wire, the map, or the pressure? Which finding matters most? And in neuro, the answer is almost always the changing level of consciousness. What could I do? What do I do first? And did it work? Which in neuro means, is the next neuro check better or worse than the last? That comparison, over and over, is the whole job. One last patient, unfamiliar on purpose. A 50-year-old man is found confused after a fall 2 hours ago. He was talking normally to paramedics, but in the last 20 minutes he has become drowsy and his right pupil is now larger than his left and slow to react. His blood pressure is climbing, his heart rate is dropping. Take a moment with that before I say anything else. Walk it. What is happening? A head-injured patient with a lucid interval, now deteriorating. Why? A one-sided blown pupil plus a dropping level of consciousness is rising pressure and early herniation, and the story, talked, then declined, is a classic epidural bleed. Which matters most, the pupil and the consciousness, together, right now? What first? This is an airway and neurosurgical emergency. Protect the airway, position to lower pressure, and get the surgeon and the CT immediately. And the rising pressure with the slowing heart rate is Cushing's, the late sign. This patient does not have an hour, everything you needed was in chapters 2, 3, and 7. If you keep 5 things from this course, keep these. 1. The brain is crossed and language is usually on the left, so right-sided weakness with speech trouble is a left brain problem. 2. The skull is a closed box. Rising pressure shows first as a falling level of consciousness, and Cushing's triad is late. 3. The GCSU trend matters more than any single value, and 8 or less means protect the airway. 4. In a stroke, CT first, because you cannot give a clot buster to a bleed, and time is amber turning gray-blue. 5. In every neuromuscular disease, the emergency is the diaphragm. Watch the breathing. And back to the quiet room where we started. Eleanor, right-sided weakness, unable to find a word, last known well around 8:15. You had no framework for that at the start. Answer it now. What is happening, and what is the single most important next step? Left hemisphere ischemic stroke, in the middle cerebral artery territory, inside the treatment window. The single most important next step is an immediate non-contrast CT to rule out bleeding because everything, the clot buster, the thrombectomy, all of it, waits on that one scan. Same quiet room. Same 15 minutes of assessment. Completely different nurse. That is neurology. Not a list of diseases, but 3 ideas. A wire that carries signals, a map where location is everything, and a closed box where pressure is the enemy. There are over 1,000 free study guides at clinicaljudgern.com, no paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who catches it while it is still amber.